What happens? They continue coming over an unlocked foot. The first metatarsal is still free to move on its axis. It moves up and out to the side. And you hear this. I had a bunionectomy 5 years ago. My bunion's coming back. Why? We treated the symptom. We left the underlying disease. We didn't change the way they function. And form will follow function. But I said lower the head of the first, and you can't do that. If you've got a flat foot, the only way you're going to lower the head of the first is to dig a hole. And I'm not suggesting we dig a hole in their shoe. What I'm really saying, instead of lower the head of the first, is supinate the foot. Raise the arch. The only trouble is you can't explain it that way to a patient. You can't say, I'll be supinating your foot. They'll say, what soup do you have today? You say, I'll be taking your flat foot and lowering this bone to create an arch. That they can understand. So throughout this course, I'll be saying lower the head of the first. What I want you to be thinking is supinating the rear foot, raising the base of the first, raising the arch. Well, you get 3 chances to help anybody. You could wait till after surgery. Now, if a person's had surgery on bunions or anything I'm going to talk about, you immediately tell them, we're going to put you in an orthotic device. Why? People don't get surgery because they looked in their benefits book and they go, ooh, I get a free bunionectomy. They get surgery because they're in pain, and the surgery's no picnic, and neither is the post-op. So if they've had surgery for something, the symptom has been treated. It behooves you to treat the underlying disease. Treatment. If you could get to people early enough, they won't need surgery. I tell you what, I've spoken to so many surgeons who found that when they put their patients in this, up to 40% of their surgeries cancel. People can reverse deformities without surgery. It's a wonderful option, but the best treatment of all is prevention. If you could get to people before they even develop the deformities, they'll never develop them. And the gold standard of prevention is children. University of California, Berkeley Laboratories did a wonderful study. They put kids in their UCB, which is a very rigid brace, and they found that when they put kids at 1.5 years old, 40% more than the control group developed normal arches. At 3.5, 11%. At 5.5, 1%. Form follows function to a much greater degree when there's still plastic and elastic deformation available in the epiphyseal growth plates. In other words, when you can move those soft growth plates in the child. So children are the best candidates for preventive orthoses. Second diagnosis, dorsal bunions. Interesting phenomena about the first metatarsal phalangeal joint. When you push up on the first metatarsal phalangeal joint, the toe locks. It will not dorsiflex. Try that. Put your thumb under the head of the first, push up, and try to dorsiflex the toe. It won't move. It jams on its dorsal surface and opens up on the plantar surface. When this happens over and over again, you eventually get an arthritic lip forming on the top of the bone. We call that eventually hallux limitus or hallux rigidus. Now, as podiatrists, we don't take any lip. We take a hammer and chisel and we knock it off. Now the patient's in twice as much pain. Why? You took bone that was hitting bone, you turned it into raw, just cut bone, hitting raw, just cut bone. And when we mess up in surgery, we often send them to therapy. And what does the therapist do? Well, I got the answer. We'll use distraction and range of motion exercises. You might as well bang your head against the wall. As long as they're coming over an unlocked foot and the first metatarsal is moving up, it's going to jam dorsally.